is CORDIScovery. Hello and welcome to this episode of the CORDIScovery podcast with me, Abigail Acton. Today we'll be talking about innovations in European healthcare in the wake of COVID-19. Healthcare professionals working flat out for a year, living through experiences nothing could really prepare them for, health systems stressed to breaking point, a population facing fear, insecurity and grief without the human contact to make these bearable. The pandemic will cast a long shadow. Dr. Hans Kluge, the World Health Organization's Europe director, warns we are facing a growing mental health crisis, the impact of which is likely to be long-term and far-reaching. Can technology help ease the burden on healthcare providers when it comes to treating mental health challenges post-COVID? Prevention being better than cure, now more than ever, can next-generation sensors help people recognize and anticipate their mental conditions, making them easier to cope with? Having been deprived of much human contact over the last year, will people want to turn to devices for insights, or will they be more dependent now on healthcare professionals? And how can Europe's financially stretched health systems identify what new devices to provide, which will benefit patients and which have limited use? The looming post-COVID mental health crisis makes insights from today's guests more valuable than ever. Welcome to Lars Montelius, the Director General of the International Iberian Nanotechnology Laboratory. He is the Professor of Nanotechnology at Lund University, Sweden. Lars is also the founder of several Swedish companies working in the field. The interface between nanotechnology and life sciences is one of his many interests.
Hello, everyone.
Corina Sas, Professor of Human-Computer Interaction and Digital Health in the School of Computing and Communications at Lancaster University, is interested in human-to-computer interactions in which emotional information is communicated by the user. Mental health technologies are one of her interests. She coordinates the EU-supported AffectTech Innovation Training Network. Hello. Eleanor Phillips is based at the Hamburg Center for Health Economics. Eleanor is a managing director of the ICQE project, which received funding under the EU's Horizon 2020 program. Her areas of interest include digital health and mobile health research, with particular focus on digital interventions for mental health.
Hello also from my side, and thank you for inviting me.
Alexander Tobica, Associate Professor at the Department of Social and Political Sciences, is the Director of Center for Research for Health and Social Care Management, CERGAS, at Bocconi University in Milan. She is the President of Italian Health Economics Association, AIES. Alexandra is particularly interested in the impact of economic analysis on decision-making in healthcare and has been recently focusing on exploring different methods of analysing this interplay. Alexandra was involved in the EU's COMED project.
Hello, everyone. Nice to be here with you.
Hello and welcome, everybody. Lars, if I could start with you. Nanotechnology and nanoscience are fascinating areas and frontiers in ongoing research and science. There seems to be so much potential and capacity for these technologies that we're really just touching the tip of the iceberg. Can I ask you how they are being harnessed to create the next generation of sensors? Could you tell us a little more about the potential of these technologies and the benefit that they can bring to sensors and medical devices?
Yes. So first of all, I would like to say that sensors, they are really a part of the digitalization. So digitalization is about data and processing data. But in order to have some data to process, you need to measure something. So that's where the sensors come in. And now, as a consequence of the microelectronics and nanoelectronics, these sensors can be very small and they can also be very affordable. And they can be very precise and tailored to a certain specific function. And they could be invasive or they could be non-invasive.
May I stop you for a second and ask you what you mean by invasive and non-invasive?
Yeah, a typical non-invasive is something you have on your body, for instance, if you talk about a health sensor. An invasive could be something that you have inside your body. It could be the pacemaker. Or
right, implanted or not implanted.
Implantable, yes. Right, if you talk about the body. It could also be in other bodies, not human bodies, right? It could be implanted in machines, etc., etc. So, but these sensors are, of course, very important. And now with the increased speed of communication from the sensors to some kind of decision platform or some kind of orchestrating layer in your mobile phone, your user experience or whatever, the speed of the communication enable these sensors to take real-time decisions. And that's what makes autonomous driving possible in the future, because we will have now with the 5G the possibility to have a car being taken decisions by itself on the edge.
But also real-time prompts to the user or the person who's
Correct.
gaining the
Correct.
data. Okay, that's interesting.
Yeah.
And how does nanotechnology and nanoscience fit into making these more, I can only think of the French word performant, more powerful?
Well, I mean, this is the whole basis for sensors, because they are based on materials, and you kind of tune the material's properties to get a certain function. For instance, if you would like to measure pH or glucose level in blood or whatever. So you tune them for something specific, and you use as little material as possible to make them small, so they be, easy to integrate, but also with the function you need. And that where is nanotechnology is all about, is to understand the material properties at the nanoscale and tailor them to a certain function. And then, of course, when you have these sensors and they are connected, in a connected layer with each other, talking with each other like IoT products, or what we nowadays call nano IoT products. They will exchange the information, and that network in turn will be able to give information to a user and nudge you to do certain things. So you can think about these connected sensors as a kind of a network that is, let's call a guardian angel for you. It will nudge you to avoid dangers. And these dangers could be in traffic, but it could also be dangers in your health.
So almost like a safety net, one could think.
Yeah. You could think it like a safety net, or these kind of safety pillows that blows up in the car.
Yeah.
Right. So it's kind of, you don't see it, but when you need it, you will notice it.
And so the nanotechnology element, of course, is the ability to both reduce in size and also, I imagine, enhance in performance.
Yeah.
So the reduction in size plus the enhanced performance.
And the reduction of cost.
Right, yes, because less material.
Which enable the possibility to deploy them in large scale, right?
And how could these be used in health surveillance? Since today we are interested in health in a post-COVID world, how could these be used in that application?
Yeah, you can think about them of collecting all these kind of different data, right? So the data could be collected through your skin, for instance, glucose level, or it could also be through some body liquids. So you can imagine a contact lens, which has a glucose sensor measuring the glucose level in your tear liquid, for instance. And all these data could be integrated in your body in some instances. If you are having some kind of surgical treatment, you could place a sensor there if you like. But I think the most important thing is the pattern that is generated by this data. And that is specific one specific person, and then compared with all the other population, of course. And it's a variation of the data that gives you the early warning.
Right.
And that could be done to tell you you're soon getting sick.
Okay.
So you can actually be prevented and stay healthy rather than getting sick and you need to go to the care. So it's a kind of turning the health system upside down, right?
Yes, basically prevention being better than cure.
So starting with the sensors and then have a healthy living.
Yeah.
And avoid going to hospitals.
In the first place, which of course after the coronavirus crisis is more important than ever with health systems.
It is, for sure.
Facing such enormous backlogs of non-related COVID conditions.
Yeah, so I think in this perspective, I think the interesting thing with a virus or so is that with these sensors being, for instance, in the sewage system, in an elderly care or hospital, or even in your homes, in the air, in your home, etc., that can provide information about the spread of the infection, right? And that will give information, of course, to the collective or to society, but also to you as a person. So it's all about the connectivity. So by having them connected, the society can take advantage, and you yourself can take advantage of the specific things. And so I think here there is a very interesting possibility for the future to have these kind of systems to help you to monitor air quality, for instance, in your home or in your office or in the hotel room or whatever. So I think this is the possibility for the future.
Yeah, great potential, great potential. And thank you, Lars. And this kind of takes us to Corina, your area of interest, which is you were involved in the EU-supported AFTEC project, which tried to develop prototypes to demonstrate how sensors can help people manage mental health challenges. Obviously, with the pressure that we've all been under, mental health is an issue that concerns many more people than perhaps before the crisis. So this is more relevant than ever. Talking, as Lars was, about the use of sensors to allow people to behave proactively, what parameters were the sensors tracking in your AFTEC project, and how could people benefit from the insight provided?
That's a very good question, Abigail. We used particularly biosensors measuring perspiration and heart rate, and these are bodily functions that operate without conscious control. Perspiration is a sensitive indicator of changes in the intensity of our emotional responses. And another one is heart rate, measuring the number of times our heart beats per minute. And for example, under stress, we experience higher emotional intensity, which leads to increase in the sweat and heart rate, a little bit of what's happening with me right now. In our work, we did capture these changes of emotional arousal through biosensors. And their main benefit is bringing these unconscious bodily processes to our awareness and ultimately under our control, conscious control. Biofeedback provides people access to biodata that signals, for instance, this sharp increase in emotional intensity during stress. And by accessing such data, people might learn to consciously control these specific bodily functions.
So you're giving people the information they need in order to be able to recognize that they might have some sort of crisis coming. What did the project actually develop? Did you develop the sensors themselves? And if so, did you find that there was any market interest in these?
So we often use commercial sensors, but we worked at the level of what we call the way they are represented, actuation. And I can give you a couple of examples of the stuff that we are developing with a range of research prototypes. A few of those are wearable devices to be worn on the wrist. For this, we have used biosensors, again, the ones measuring perspiration or heart rate, and we integrated them with novel interfaces for representing biodata. And we used color, vibration, or temperature-based biofeedback. So when people experience, for example, an increase in their emotional arousal, they can immediately see, feel on their skin this feedback, which can be either static or animated shapes, changing colors, could be subtle vibrations or gentle warmth.
Right.
And this biofeedback helps them to become more emotionally aware.
Right. And with that awareness, is, the data and the access to data is fascinating. And of course, we're exposed, if I can use the word exposed, to more and more data. There's data everywhere. What makes these devices very interesting is that there is a dimension where people can harness that data to actually change their behavior slightly. Otherwise, it's just data. So did your devices also come with some kind of mechanism that would inform the user what perhaps would be a useful thing to do at a certain point, like take a step back and breathe deeply for 5 minutes or something like that? How did that work?
That's a very good point, because of course, emotional awareness is just the first step. To address exactly what you are suggesting, we developed other interfaces, other types of interfaces, providing visual and haptic, again, representation of slow breathing and slow heart rate to help people actually lower them and calm down. And we built some smartwatch applications guiding people to slow down their breathing rate. We use visualizations through which people can inhale and exhale, following, for example, a slowly expanding and contracting circle. And another smartwatch application delivers vibrations that are 40% lower than users' current heart rate in order to guide them to lower theirs.
Yeah, and that's very interesting, isn't it? That's almost like a target to reach, but yes, in a way that's perhaps more calming than thinking of the word target, which automatically is competitive and therefore not very tranquilizing. But yes, it's almost like you're following the lead of something that is showing you what direction you should be going in. Yeah. Like something's holding your hand almost. It's on your wrist, but it's almost holding your hand.
Yeah, absolutely. There's a lot of comfort in that gesture.
Indeed. Thank you. And are you finding that there's much interest in market take-up? How is that going?
Yes, we are pleased to say that these devices have been recognized as innovative by the EC's Innovation Radar Prize. And we are now focusing on taking them to the next stage needed for the market. We received some interest. We are in conversations with potential investors, but I like to take this opportunity as a call for interested investors to reach out to us if possible, because I think it's exciting work which deserves to move forward.
Absolutely. No, please do. Anybody interested, then contact Corina. Very good idea. Lars and Corina, you've been talking about sensors, the technology behind the sensors, and the application of that information and that data to benefit the user. Could I ask you all if you would have any questions to Lars or Corina, or you might have questions for each other about this aspect of today's conversation?
I mean, there is one aspect that I think is interesting to think about, and I think, I mean, now in this sensor we discussed, it's something that nudges the person, the individual, of course, to take better decisions. Let's call it like that, right? Or behave better or whatever. The other aspect is, of course, who owns the digital data and who can take advantage of that, who can valorize it, who can sell it, etc. So my data, I should own it, right? Not the guy who make the device or give the software to me that I have some kind of relation with, right? So I think, and this is questions that is not yet really discussed, right?
No.
In my mind, at least, what I know. Right?
No, I think you're right. It's because it's also cutting edge and new. We're almost at the stage where the technology is overtaking society's reactions to the technology.
Yeah,
indeed.
No, I think it's individual is fine. I mean, because I get the information, so I can behave better, so I have a better life, whatever, right? So it's fine. But there is also another dimension to this, and that is how, if someone else is taking advantage of that, then I would also like to have a piece of that pie. Right?
Sure. Yeah, of course. How is it going to be marketed? Yes. Is it going to be useful for someone to contact you and tell you that it looks like you're going to need more diazepam or something because you seem to be stressed? Yeah. Yes, exactly. Okay, very interesting. Any other questions for Lars and Corina?
I have a question.
Yes, please, Elena. Yes.
But actually, it could go for both, for Corina and Lars. I'm interested in acceptability from patients or from participant sides. How does it feel to wear sensors? How do people respond to this? I would be interested. Did you make any studies on this? And another question to Corina. I wonder, this awareness of the emotion, how does it change the emotion? I was thinking of. Did you make any surveys on that or any investigations?
Yes. So to answer the last question, the awareness of emotions. Yes, when people become aware, they start to understand a little bit. They have the process of understanding where emotions came from, what has caused it, try to see patterns between similar contexts that have led to the same kind of negative feelings, and realize in a very visceral way the importance of stepping back, breathing in, breathing out, relaxing, even without the regulatory aspects implemented directly on the stack. So even those supporting just emotional awareness offline support people regulation as well, prompt people to regulate.
Yeah, so basically it's providing a context for people to recognize perhaps that there's a pattern. So you could think, well, I feel fine in a certain situation, then in fact, perhaps you are not as fine as you think you are. So the next time you're in that situation, perhaps you realize that you need to take a step back. Lars, going back to you, I mean, we were talking about nanosciences and nanotechnology and the benefit of that being that things are shrinking in size. Absolutely. I mean, I'm an Apple Watch wearer and I'm quite comfortable in my Apple Watch, but it does feel a little like I've got a computer on my wrist. I mean, you know, I do feel a little self-conscious, especially if I take a call on my wrist. I feel like an idiot. What's the future for these type of wearables? Are they going to get ever smaller?
I think that will be both smaller maybe and also integrated in different ways. I mean, one of the most interesting sensors that do very much, the Apple Watch is a sensor in a way because they measure a lot of things, right? Besides being a watch and information provider, a personal digital assistant, whatever. But there are other kind of form factors now with rings, for instance, that give the same kind of thing that you can wear as a ring. And I think the acceptance is really to find what is social acceptable, so to say, right? Because I mean, nowadays more and more people are having what I have. I mean, earphones, and you are going in the street and talking with yourself, etc., and it's becoming acceptable, right? Which was not the case when I was a kid. It was totally unacceptable if you would do that. So I think it will change, but I think it will be integrated more and more in different things. And you can have sensors in your fabrics, in your clothes. You can have it under the skin. I mean, you can have tattoos being printed on your skin, for instance, that are sensors. And you can integrate it in your glasses, and so there are a lot of things. And I think the social acceptance about these kind of, if you call it, in a way, maybe it's not individually performance enhancers, but in a way it is, right? So glasses is also an individual performance enhancer, which is totally socially accepted. Hearing aids, the same. So I think with time, it will not become complicated. And I think if it is not nice to wear, no one will wear it, right? So I think the wearability, the user experience, will be the dominating factor for this.
Right, absolutely. The design, yeah. Eleanor, I'm just going to turn to you now, if I may. We were talking earlier, and one of the things that we were sort of almost laughing about was the notion that just because the technology exists, should we actually necessarily use it? So there's sometimes a feeling that we're able to do things, and so we do them, but we're not necessarily paying attention to whether the people who will be using these things want them in the first place. So one strand of the IQCE project analysed how people feel about the use of technology to overcome mental health challenges. So rather than what we were talking about with Corina about noticing what's going on in your body or in your reaction to stress and perhaps taking action to try and mitigate that, here we're actually talking about therapies and treatment for people with mid to low level mental health challenges. So can you tell me what the IQCE project was seeking to establish in this particular strand of it, and a little bit about your methodology?
Yeah, so just to give you a bit background information, our research focus were so-called e-mental health interventions. And these are interventions that are based on CBT, cognitive behavioral therapy. And they are designed for people who have mild to moderate symptoms. And they enable people to work by themselves at their mental health problems. So, and the recent scientific evidence suggests that such interventions can be effective. But also there is evidence that people or patients are still quite hesitant regarding uptake of those interventions. So we were curious, why is this like this, and how could we maybe increase the acceptability of these interventions? So we wanted to shed a bit more light of this hesitation. So we conducted a discrete choice experiments among almost 2,000 participants in Germany. And in this experiment, we wanted to see the preferences of participants for singular features of those interventions. So to give you a concrete example, what we have done. So we defined the interventions by specific features like content delivery, like peer support, like proof of effectiveness, or human contact, or let's say form of human contact. And human contact, I will go here a bit deeper. We offered several levels of human contact, such as no human contact via email, human contact via phone call, video call, or it was the last option, human contact with the psychotherapist in a traditional psychotherapy session, and the mental health interventions would be a part of this therapy journey process. So, and then we asked people, so what would you prefer? And well, the result was surprising, because the most preferred feature of the mental health interventions was human contact, and then in context of traditional psychotherapy. So basically, it was a questionnaire survey about digital technology in mental health, but we came up with the strongest preference for human contact in this area.
Could I ask you, I mean, that was the patient's perspective.
Yeah.
So yes, we're interested, perhaps they said we're interested in various options and concepts and technological advances, but what we really want to do is sit down and talk to somebody face to face. What was the therapist's reaction to the notion of blended care, as you would call it, a mixture of E interventions and human intervention? What did the therapist think?
Yeah, it was our next project. We wanted to see the perspective of German therapists on it, because there is a difference when we talk about therapist view on mental health or blended care. When you mix psychotherapy and technology, there's a big difference among countries, healthcare systems, and among therapeutic schools. So CBT therapists are naturally more open to mental health interventions, whether psychodynamic therapists or humanistic therapists are more hesitant. So, and we got a similar picture in our last study. CBT therapists were very welcoming, where the psychodynamic therapists, they valued more time, more personal time with the patient. They opted for larger shares of personal sessions regarding to digital interventions. But both therapists were both schools in our survey were quite positive regarding this mixed blended care treatment form. So they were both optimistic to integrate the technology into the therapeutic process. But the preference was as you can blend it in different forms. You can integrate the technology in the therapy process, or you can do it before or after therapy. So the preference in our survey was to integrate digital interventions into the therapy process. So the parallel running.
But it's an interesting idea that perhaps the digital therapy could be used also as a backup. You know, that people could reinforce what they had come to understand or realize with the psychotherapist through a follow-up using digital therapy and perhaps games and so on. That's very interesting. Thank you, Eleanor. Does anyone have any questions for Eleanor about this? Yes, Corina.
No, very interesting project. I know that the cost of providing this human contact is very high. And I'm just wondering, what's the appetite for people to explore peer support in talk therapies?
Peer support, basically the levels for peer support we had was a possibility of an online community, on moderated online community, or face-to-face meetings with the moderator. But peer support didn't play such a big role, and here again was a preference for more human contact. But when we look at all features, peer support didn't play a big role. It can be our hypothesis was that mental health is quite, for some people, stigmatized topic. So there is not this big openness to connect with a lot of people, but there is an openness to connect maybe to one person, like a psychotherapist.
Yeah, it feels like it's private, doesn't it?
Yes, like a more intimate connection.
Yeah, no, that does make sense. I think that would resonate. That makes sense. That interesting point, Corina, you made about the cost. This is actually Alexandra, sitting here very patiently. Hello. This actually chimes a little bit with what you were looking at. So you were involved in the COMED project supported by the EU, which aimed to make sense of all these new devices and sensors and other new technologies and advances coming onto the healthcare, if I can say, market, by establishing ways to measure how effective they are and suggesting parameters healthcare providers can use in order to decide whether or not to offer them. Since the long-term cost effectiveness of clinical devices and sensors and everything really depends heavily on how they are adopted into routine clinical practice, if they're brand new and haven't actually been adopted that much into routine clinical practice, how can healthcare systems determine which innovative projects and devices to provide?
Thank you, Abigail. Thank you very much. Indeed, at the end, but this is, not usually that is the case, because the journey of the new technologies innovation is really, as we have somehow followed in this podcast, like from the very, very basic research and the innovative solutions to patients' preferences, and then at the end, somebody has to pay for it, right? So what are the criteria that the policymakers put in place in order to decide which technologies to cover with limited public funds? So basically to guarantee coverage and reimbursement. So to face and to overcome so-called fourth hurdle that the innovations have to make before they come actually to the final user, which is the patient. So if you think about all the innovations that we have heard about through the interventions of my colleagues here, at the end of this journey, the technologies need to be evaluated across some dimensions. And policy makers more recently in Europe, but not only Europe, have been using this framework of health technology assessment that looks into clinical effectiveness, but also cost effectiveness, economic impact of these technologies when they are used in real life, in real world, on the real patients. So for the medical technologies, especially for the very innovative one, like we have heard about today, it is really, the uncertainty around the effects in real life is huge. Once they have, come to the market and they have obtained all they had to obtain in order to get, the market license. Because this gap between the evidence that is needed, this is especially true for medical devices, not so much for pharmaceuticals. So the evidence that is needed to get the CE mark, for example, in Europe, to get to the market, and the evidence needed to pass the health technology assessment evaluation, there's a huge gap. So what do policymakers do in front of this gap? Traditionally, with a yes or no decision, so yes, we pay for it, no, we don't pay for it, the whole risk was on the burden of the policymakers. They take the risk of saying yes to something that is not maybe cost effective or effective at all in the real populations. If they say no, they take the risk of not granting access to patients for something that potentially could really improve their lives. So this idea with this new innovative arrangement that was one part of COMED project was that to share the risk between the manufacturer of the innovation and the policymakers with these innovative policy tools, I would call them, how to allow quicker access to innovation, but by sharing the risk, reserving some let's say, potential to even reverse the decision in case the evidence proves that the technology is not good enough to be used on a wider scale. And these policies are labeled different ways, different names in different countries. Coverage with evidence development was one way that we use it, especially in Europe, to label a set of policy tools that are basically what the word itself says. I grant you coverage and reimbursement provided that you generate evidence that I need to make a more robust decision. In this way, the manufacturers and producers share the risk of generating the data, but also obtaining safe and effective and cost-effective devices on the market.
That's fascinating, and it makes absolute perfect sense. So basically, as things develop and the context changes because new technology emerges so quickly now, basically what you're doing is permitting people to accept that there's a gray area, that it's not black and white.
Exactly.
And that we don't stall everything in favor of trying to get something that is a simplistic overview, but that we acknowledge that there's some ambiguity and that we proceed and progress, but that decisions can be changed if needed. That's, I think, what you're saying.
Exactly, because the main purpose of this coverage with evidence development schemes is really to reduce the uncertainty about the effects, whether they're clinical and economic effects of a specific technology, by obtaining data on real patients, which may not be in a position to obtain for millions of reasons before the technology comes to the market. The wider use is not possible before, of course, the technology is available to patients, to physicians, to hospitals. So rather than saying no because evidence is limited, we say something in between, as you said. So yes, but provided that you generate evidence. Sometimes those decisions can be only in research, so we allow it to access a limited number of patients to conduct more research, or only with research, so wider scale, but with the research generating the data. this is especially challenging for the technologies that we have discussed today. So wearables, for example, there is still no agreement on what do we actually have to measure as effectiveness of wearables, because the health technology assessment framework was somehow built on pharmaceuticals, where we look at the mortality rates, we look at some surrogate outcomes of blood pressure or other indicators, of course, that we are interested in. How do you measure whether a wearable is effective? There is a whole range of dimensions that are not captured in traditional frameworks. So, allowing this gray area really, opens the door to evaluation of different types of technologies. And we know that medical devices, we have, I think 500,000 of different types of technology that we label as medical devices, and not the same rules can be applied to all of them.
So I think also it must be the case that people become more courageous. Healthcare providers become more courageous because they're not locked in to financing something that they then decide they don't want to finance anymore. They can change their minds. One thing I was going to say also is that it must be very difficult, and this is perhaps for Lars and Corina and Eleanor too, it must be very difficult to prove a negative, no? Because what you're saying is that if these people hadn't been wearing these devices, their condition would have worsened. So with pharmaceuticals, you say, I take this tablet, I get better, things improve.
But there are study designs that can allow you to do this analysis, okay? So, I mean, so-called counterfactual or control group, there are ways you can do it with the study design, but of course, there are limitations to that. That's why, sometimes like conducting a trial in a pre-market phase will not be feasible or even ethical for some of these situations. So once it's on the market, you would need to think through with the manufacturer. This is also the possibility for the manufacturer and the payer to come together, decide on the design of the study, share the risk, but also share the knowledge on a specific issue, and also providers to be part of the evidence generation process, not just the recipient of, but really an active actor, protagonist in generating evidence, which then it's not only about being, I think, courageous, but really being more involved and having more governance tools to allow, again, quicker access to something that can really improve people's life, but also having, let's say, a bigger influence on how the money is being allocated, because we know that, of course, that, innovation, the speed of innovation is so high, but the resources are, by definition, limited.
Yeah, they remain the same, even though the amount of choices
even if
increase.
they grow, they will never grow as fast as technology.
As fast as the choices provided. Can I thank you, Alexandra? It's fascinating and it makes perfect sense. It's one of these wonderful things where, until someone's pointed it out, you haven't thought of it. And then when someone points out that the system needs a slight shift in the way that it approaches these novel technologies, it just makes perfect sense. Very logical. Alexandra, I would have one more question to you. And that would be, did you find that it's a little bit like a disruptive technology, your own approach, really. Did you find that healthcare authorities are interested in embarking in a new direction in this way?
We did, in Common Project, evaluate really what are the perceptions of policymakers vis-a-vis these new policy tools, because so far, most of the, experience has been generated in the world of pharmaceuticals, where things are a little bit more structured and controlled and established than in the world of medical devices. So the policymakers do recognize the great potential to this new tools, especially in the field of medical devices, given these uncertainties that we talked about and then lack of evidence and so on. There are, however, a series of challenges and criticalities, as always, in order to fully implement these schemes. One, maybe the most important one is really resources available, because doing this properly costs also, to build up a proper coverage with evidence development scheme really requires some investment also from policymakers. So it has to be worthwhile. And when is it worthwhile? When the purpose of the scheme is really to generate evidence that will be used. If for a policymaker, it's a more rational decision to just to do some price negotiation with the manufacturer. Say, whatever evidence you have, let's just talk about the price and to see what would be the best deal, to put it very simply. Then it may not be worth to invest all this money in building the structure of coverage with evidence development. But if there is really a need to close the gap on the uncertainties of evidence, then the policymakers are very open to these new avenues.
Yeah, I'm sure.
The issue of funding and availability is fundamental because different countries adopt different models. Who pays for this?
Yeah.
Is it the Ministry of Health who wants this evidence? Or again, the funding should come from the manufacturer. But what is then it for the manufacturer? What about if the results are negative and they are even being, they paid for something that will then make them reverse the decision on reimbursement? So it's not as simple.
No, it's balance. Absolutely. Yeah, no, I can imagine that in some situations, perhaps people would rather just negotiate the price and then walk away and have the certainty of the fact that their device has been adopted and that they're contractually obligated. Yeah, it's interesting. But it seems to me to be the way forward, given what we've been talking about now with regards to cutting edge technology. I have one question now that I would like to ask each of you. It's perhaps a little predictable, but I think it's really worth asking, especially given the subject today, because we're talking about almost slightly futuristic tendencies in healthcare and provision. So I will go around the table. I will start with you, Lars. What do you imagine the next decade will bring?
I think strongly that we will have this kind of interconnectivity with different kind of sensors that will help us to stay more healthy, but also help the care to give better care and better kind of treatment. And I think one of the challenges is how can the new knowledge being generated by all these kind of sensors, how can that be incorporated and linked to certain kind of diseases or certain kind of treatments that we should do? How can we link that into the, let's call it, education sector, right? Because it's so quick, it's an exponential growth of data. And how can that kind of exponential growth be incorporated into the educational programs? Because otherwise it would be difficult for doctors to, you come with all your data and say, here is my data. And what I see, you sleep not so much and you have this blood pressure. What shall I do with that?
Yeah.
So I think this is the kind of challenge for the future.
Actionable data.
Yeah.
Thank you, Lars. Corina, next 10 years, what's going to happen? Crystal ball.
I go with Lars' prediction about interconnectivity. I will add to that, I can see multiple layers of things. Things will be weaved in the fabric of our lives without really seeing those actuators, those sensors. I think through speech inputs, we'll have access to a range of therapies and biofeedback devices. There will be multiple layers. But to me, it's really about how this personal data becomes big data and how AI can revolutionize this space. There is a lot of work already ongoing. And to me, before we get there, it's the issue of ethics. And again, who's owning the data, which business models are underpinning them. I think there are big philosophical questions we have to ponder over in order to really push this field forward from very solid foundations.
In an ethical way. Yeah, interesting. Yeah. Elena, next 10 years, what do you think is going to be the case when it comes to how people approach treatments and perhaps use e-therapies and so on?
I guess I would touch the big philosophical questions because I'm more in the mental health area than in the technology area. So I see the bright future in the area of self-empowerment, of patient empowerment, on prevention. So I think these are great potentials of all these developments we discussed today. I also see that these devices and technologies give us a sense of control that we can have over our lives. And this sense of control, it's interesting how real it is actually. And what I also, my biggest takeaway from this discussion came actually from the Corina's question or remark that the therapist contract is an expensive factor. So I was thinking that actually, yes, the human contact, the human connection is the most expensive factor, but it's also the most valuable one.
And if we're thinking about the overall cost to society of somebody who is perhaps suffering from mental conditions, then perhaps the most effective therapy is the one that ultimately is the cheapest. Alexandra, next 10 years, what's it going to bring?
Well, so I'm not sure whether, I have a crystal ball. I can tell you what I hope for.
Yeah, that would be good. Tell us what you hope for.
Actually, I do hope that these are the two out of the many lessons that we can learn from the current pandemic as well, because I think this is something that we should learn from what is going on in the world. The first one, the centrality of health in all policy decisions. It's not only about the domain of health policy or Ministry of Health, but the health is central for economy, for finance, for social systems, for health is, a cross-cutting theme. And, I do believe and I do hope the policymakers of all the countries will, realize that we are paying the high price to realize it. So that this is something to revert the discuss, to change the narrative about healthcare in terms of spending and costs to investment for the future in terms of also economic development and not only. And the second hope is about really opening our eyes on the importance of data and evidence to inform those decisions, because also with these new technologies, we are really overabundance of data. Make it actionable, as Lars said, and useful for policymakers who are now more open and more receptive with some criticism to science and evidence to inform, whether to invest or not to invest, to close what to open. But at least, this bridge between the science and policymakers has become so evident in the current crisis. So I do hope it will stay there solid for the years to come.
Yeah, absolutely. Absolutely. We have to come out of this with improvements to the way that we operate and the way that we think. Absolutely. Listen, I want to thank you all very much. That was truly fascinating, very, very interesting. And I'm grateful to all of you for having joined me. And I wish you all the best in your future research. And I look forward to hearing more about what's going on in your various domains in the future. Thank you for joining us today. CORDIScovery says thank you very much.
Thank you.
Thank you.
Thank you all. Bye.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye.
Interested in what other EU-funded projects are doing to transform European health systems in the wake of COVID-19? Take a look at issue 101 of the Research EU magazine, available on the CORDIS website, cordis.europa.eu. Here you can also find daily news articles, interviews with researchers working on domains ranging from paleoarchaeology to space, results packs which drill down deeper, gathering groups of projects by subject area, and the magazine, which offers insights into a different subject every month in its special section. Interested in applying for an EU research grant? Visit the CORDIS website to see how your work relates to that currently being done in your field. So come and check out the research that's revealing what makes our world tick. Our next episode will consider how EU researchers are tackling pollution for a cleaner, greener Europe. Land, sea and air. What are the latest findings coming out of cutting-edge EU research? Join me to find out. We're always happy to hear from you, so drop us a line, editorial@cordis.europa.eu. Until next time.